Welcome and thank you for standing by. I would like to inform all participants that your lines have been placed on a listen-only mode until the question and answer session of today's call. Today's call is being recorded. If anyone has any objections, you may disconnect at this time. I would now like to turn the call over to Helen Talley-McRae. Thank you. You may begin.
Hi, thank you, Amanda. Good afternoon, everyone. My name is Helen Talley-McRae, and I work in the One Health office of the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of the One Health office, I'm pleased to welcome you to the monthly Zoonoses and One Health Updates call on October 3rd, 2018. Before we get started, please be aware that although the content of these calls is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates on this conference call. Therefore, please exercise discretion on sensitive content and material, as confidentiality during these calls cannot be guaranteed. Finally, today's call is being recorded. If you have any objections, you may disconnect at this time. Detailed instructions for obtaining free continuing education are available on our website, cdc.gov/onehealth/ZOHU, and will be given at the end of this call. Please spread the word to your colleagues about the ZOHU call and this new free CE opportunity. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, presenters, and their spouses and partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The Planning Committee reviewed content to ensure there's no bias. The presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. Before we begin today's presentations, CDC's One Health Office Director, Dr. Casey Barton-Baravesh, will share some One Health news updates with you.
Hi everyone. Thanks for joining us for today's ZOHU call, and welcome to all of our new participants. The ZOHU call audience is really growing, and we now have over 8,000 subscribers representing a variety of One Health partners. To begin today's call, I'd like to share the latest One Health news and resources with you. And again, these are included, the links in today's ZOHU call email reminder. First, in recognition of Fungal Awareness Week, we will have a presentation about multi-drug-resistant Aspergillus fumigatus during today's call. One Health Day is November 3rd, and this topic will be featured on our November 7th ZOHU call. The U.S. government's Antimicrobial Resistance Challenge was just launched, and it's a year-long effort to accelerate the fight against antimicrobial resistance across the globe. We've included some links to upcoming conferences and meetings that might be of interest, including ID Week this week and the U.S. Animal Health Association and AAVLD annual meeting later on in October. We've also shared some highlights from recent publications, including a new national biodefense strategy to protect the nation against all biological threats, interim guidance for protecting workers from livestock and poultry wastewater and sludge during and after floods, and mapping Histoplasma capsulatum exposure in the United States. We have a couple highlighted MMWR topics, and those include the assessment of state, local, and territorial Zika planning and preparedness activities in the U.S., as well as one on responding to an outbreak of monkeypox using the One Health approach in Nigeria. There are multiple outbreaks currently under investigation, and a few highlights include a new multi-state psittacosis outbreak among poultry plant workers and a new outbreak of salmonella infections linked to Gravel Ridge Farm shell eggs. As always, there's a selected list of ongoing and past U.S. outbreaks of zoonotic diseases, as well as information on staying safe and healthy around pets and other animals on the Healthy Pets, Healthy People website. If you would like for us to share news from your organization, or if you want to suggest presentation topics, or even volunteer to present on a ZOHU call, please contact us. And thank you all for continuing to spread the word about the ZOHU call, including that we offer free continuing education. So thanks again for your support and for joining us today. I will now turn the call back over to Helen.
Hi, thank you so much, Dr. Barton-Baravesh. Our overall series objectives for ZOHU call are shown on the screen here, and at the end of this call, the participants will be able to describe 2 key points from each presentation, describe how a multi-sectoral One Health approach can be applied to the presentation topics, identify an implication for animal and human health, identify a One Health approach strategy for prevention, detection, or response to public health threats, and identify 2 new resources from CDC partners. Today's presentation topics are human plague cases associated with animal exposures, U.S. 1970 to 2017, relevance of global health security on U.S. exports and jobs, emerging in the U.S., antifungal Aspergillus fumigatus associated with environmental fungicide use. You'll find resources and links for each presentation in today's ZOHU call email reminder. Questions for all presenters will be taken at the end of this call. Call 1-800-593-8936 and enter participant passcode 9611836. If you're already called in, you can just stay there on this line and press *1. Give the operator your name and affiliation, and then please be prepared to name the presenter or topic at the beginning of each question. We have a special reminder in case folks are not aware. At 2:20 today, there's going to be a new emergency broadcast alert system test happening apparently through cell phones. So we might all have our cell phones blaring at us about 2:20. So please bear with us if that happens. We might pause the presentations for a moment while we wait for that to finish. So. All right, so with that, our first presentation, Human Plague Cases Associated with Animal Exposure, United States, 1970 to 2017, will be given by Dr. Stephanie B. Campbell. Dr. Campbell, you may begin when you're ready.
Thank you, and thanks so much for having me on this call today. I'd like to start with a brief background on plague, which is caused by the bacteria Yersinia pestis. It is a gram-negative bacillus known for its characteristic bipolar staining and safety pin appearance on microscopy. Plague bacteria can be transmitted to humans in several ways. Most often, transmission occurs by the bite of an infected flea. Humans can also become infected when handling tissues or body fluids of a plague-infected animal. In addition, transmission can occur following inhalation of droplets from the cough of an infected person or animal. Although there are some other rarer clinical presentations of plague, the 3 primary forms are bubonic, septicemic, and pneumonic. Bubonic plague is the most common form of plague. The key feature of bubonic plague is a swollen, painful lymph node, usually in the groin or armpit. Septicemic plague occurs when plague bacteria multiply in the bloodstream. Pneumonic plague occurs when plague bacteria infect the lungs from direct inhalation of bacteria or is spread from other parts of the body. Primary pneumonic plague is the most severe form of plague and has a high mortality rate, even with antimicrobial therapy. Plague is endemic in several western states. The map on the top of the screen shows recent plague cases in the United States, with the red dots indicating the county of exposure for each confirmed case. The bacteria is transmitted by fleas and cycles naturally among rodents and other small animals. Humans and animals are at risk when they are bitten by these fleas, especially during an epizootic, which is when the bacteria is circulating at higher than normal levels and causing die-offs among animals, and the fleas are seeking new hosts. Domestic animals are susceptible to plague and can get sick and also transmit plague to humans by bringing them in closer contact with the enzootic cycle. We already know that animal contact is a risk factor for plague, as shown in previous literature. However, these reports address very specific questions and focused on individual animal types. The case series, as shown on the top of this slide, focus on dog or cat-associated human plague, as well as a small outbreak of human pneumonic plague stemming from a dog exposure. The case reports, as shown on the bottom of this slide, each describe a single human plague case associated with animal contact. There are certainly more questions to be answered about the role that animal contact plays and how to modify future risk of plague. In order to examine animal contact associated with human plague cases reported to the CDC through national surveillance, we established the following objectives. First, to describe human plague cases associated with animal contact. Next, to describe animals most frequently associated with pneumonic cases, since this is the most severe form. Lastly, to identify opportunities for One Health action and recommendations for plague prevention. CDC has national data for plague available to us to summarize from cases as far back as 1900. Information is available in the data for exposure details. The case report form has changed over time, with some variation in the details collected in the exact wording, but animal contact information has been consistently collected. This illustrates the information routinely collected for animal exposures occurring in the 2 weeks preceding illness, the type of animal involved, and the nature of contact, including handling sick or dead animals, butchering or skinning animals, and animal bites and scratches are recorded. We limited this review from 1970 to 2017 to examine more recent plague cases. During review of the surveillance data, if an animal type was listed in exposure source, then this was considered an animal-associated case. Once animal contact status was determined, we compared cases by demographics and primary clinical form of plague using a chi-square test or Wilcoxon rank sum test, depending on the type of variable. And now for some results. Although we didn't limit this analysis to confirmed cases, most of them were. Of the 485 cases recorded, included 33% of cases reported contact with an animal type in the 2 weeks preceding their illness. Some people reported animal contact with more than one animal type, but no more than 2 types, and the numbers shown on this slide capture that. I'd like to highlight that domestic cats and dogs make up almost a third of animal contact reported. In addition, rabbits, rodents, and squirrels, as well as prairie dogs, were frequently reported. Animals that were less frequently reported included bobcats, coyotes, chipmunks, foxes, and some others shown in the bottom box here. Plague patient demographics are shown here with known animal contact cases being compared to cases without reported animal contact. As you can see, there was a significant difference in the median age, and cases with known animal contact were older overall. One hypothesis is that since more cases with animal contact were male, perhaps the animal contact group is comprised of more hunters. We also noted a significant difference in race or ethnicity with cases with reported animal contact more frequently being white, non-Hispanic, and less frequently American Indian, Alaskan Native, or Hispanic. At this point, we cannot say exactly what the reason for this is. It's possible that this difference is due to reporting bias if cases occurred on reservations or in remote areas and less information was available regarding animal contact prior to illness. It's also possible that differences in behaviors associated with animals exist. For patients that reported animal contact during the 2 weeks prior to illness, we examined the nature of animal contact. 55% of those reporting contact handled a sick or dead animal, 32% reported butchering or skinning an animal, and 13% said they had an animal bite, scratch, or cough exposure. All of these would be considered close contact situations and could lead to plague transmission. We compared the primary clinical form of plague. Of the 15 total pneumonic cases in the records we reviewed, 11 were associated with animal contact, which was a significant difference, with the proportion of pneumonic cases among the animal contact group being greater. The proportion of bubonic and septicemic cases was similar between the two groups. The fatality rate was not significantly different between the two groups, which is interesting given the higher proportion of pneumonic cases in the animal contact group. An additional note on fatality is that the outcome of some patients in the database was reported as unknown, so it's possible that there were additional fatalities in both groups. The data shown on this slide is preliminary. As mentioned previously, some people reported animal contact with more than one animal type, and in the case that there were 2 animal types reported, the record was reviewed closer and the most likely animal type was determined so that they could be placed in a category. Additional record review is warranted. Also, only the most commonly reported animal types are shown here on this slide. Bubonic plague ranged from 55% associated with reported dog contact to 90% with reported rabbit contact. Septicemic plague was highest among those with reported rodent contact. And the biggest takeaway from this slide is that among the cases with reported animal contact, 10 of the 11 pneumonic cases had contact with domestic cats or dogs, and the 11th with a mountain lion. Records for the 11 pneumonic patients with reported animal contact were reviewed further. As mentioned, 91% were associated with domestic cat or dog contact, and the 11th pneumonic plague case occurred following necropsy of a mountain lion. 6 of 11 reported providing care to a sick pet, including administering medication, examining, cuddling, and even sharing a bed with their pet. 4 of the 11 were veterinary staff, and 2 of the 11 reported having cats that brought home dead animals within the 2 weeks prior to their illness. The takeaways from this review of plague cases associated with animal contact are: a third of plague cases had reported animal contact in the 2 weeks prior to their illness. Likely, there were actually even more animal contact cases than this, as there is additional information available in free text that needs to be teased out and was not reviewed for this analysis. Primary pneumonic plague, the most severe form of plague, is more often associated with domestic animal contact, including cats and dogs, than any other known exposure. This assessment had several limitations, including the fact that surveillance data are subject to ascertainment as well as other biases. We also recognize that misclassification may have occurred if animal contact actually existed but was not the true route of exposure, or if animal contact occurred but was not captured in this review of the database. Findings from this analysis underscore what we've already known, and that is that pet owners, veterinarians, and people with animal contact are at risk and present opportunities for intervention. In light of these findings and what's already been done previously, we are still working on recommendations. First, a One Health approach could allow for prevention of human cases, or at least earlier recognition of cases. More specifically, public health professionals can and do provide proactive alerts, such as HANS, when animal die-offs are occurring, or when plague-positive animals are recognized in an area. This analysis highlights the importance of these alerts, since many plague cases are associated with animal contact. For healthcare professionals and veterinarians, especially in endemic areas, awareness of plague is critical. Veterinarians are at increased risk of infectious disease and should ensure procedures are in place to minimize exposures, including PPE, disinfection of equipment, and isolation of plague suspect animals. Healthcare providers and veterinarians should take advantage of the opportunity to communicate with pet owners and patients regarding the risk of plague when appropriate. CDC would welcome any feedback or other ideas on how to improve public health practice and implementation of these recommendations. Thank you to my supervisors at CDC and the Division of Vector-Borne Diseases for their support with this project.
Thank you, Dr. Campbell. Our next presentation Relevance of Global Health Security on U.S. Exports and Jobs will be given by Dr. Cynthia H. Castle. Dr. Castle, you may begin when you're ready.
Thank you. Can everyone hear me?
Yeah, thank you.
Okay, great. I just didn't know with that emergency alert going off if the phone would actually still work, so thank you for confirming. And thank you for the invitation to present today. And so we're going to take a slightly different turn and talk about relevance of global health security on U.S. exports and jobs. And I'm going to discuss two sister publications, both of which have recently published in health security on this topic. Sorry, I'm just going to advance the slide. So as you see here on this slide, this is the outline of the presentation. So I'm going to give a brief background of sort of on global health security and U.S. exports and jobs, the rationale for these two studies and the objectives, and then discuss the methods, and then give you just a very select high-level findings from these studies and discuss some public health implications. So many challenges exist worldwide that increase the risk of outbreaks and impede prevention, rapid response, and containment of health security threats. These challenges include increased risk of infectious pathogens spilling over from animal reservoirs to human hosts, deployment of antimicrobial resistance, spread of infectious diseases by global migration, acts of bioterrorism, and weak public health infrastructures. In addition to these increased risks, the efficiency of the global transportation network means that an infectious pathogen can be carried from a remote village to major cities across 6 continents within 36 hours and can cause a large-scale outbreak or pandemic. We know that diseases spread faster and farther than ever before. We also know that outbreaks and pandemics can have a tremendous economic impact. For example, Lee and McKibben estimated the global impact of the 2002-2003 SARS epidemic was almost $40 billion globally. Lastly, at least 70% of countries are not prepared for an outbreak if they are not in compliance with the 2005 International Health Regulations. To prevent large-scale outbreaks, the U.S. CDC is working with partners in 49 global health security priority countries to improve the capabilities of public health infectious disease laboratories, workforce, and surveillance, including zoonotic diseases and One Health and emergency management and response systems. These activities enhance global health security by building national capabilities to prevent, rapidly detect, and to control infectious diseases outbreaks at their sources before they cross borders and cause widespread health and economic disruption. To better characterize U.S. economic linkages to these 49 health security priority countries, we assess the value of U.S. goods and services exported to these priority countries and the number of U.S. jobs supporting these exports. We also quantify the extent of economic vulnerability to the U.S. export economy posed by trade disruptions in these countries. Lastly, using the same data sources and data, we examine the impact of a hypothetical outbreak on the U.S. economy. Now to the methods. Oops, hit the wrong button. We defined global health security priority countries as meeting one or both of the following inclusion criteria. Countries designated by the USG as Phase 1 or Phase 2 countries under the Global Health Security Agenda, and countries hosting a CDC Global Disease Detection Center. We use 2 main data sources for these analyses, which are listed here: the International Trade Administration's Trade Policy Information System and the U.S. Department of Commerce Bureau of Economic Analyses. And we used 2015 data, which at the time was the most recently available data for these projects. We analyzed the data in 2 parts. In part one, we assessed the value of U.S. exports and jobs supported to these 49 countries. We also calculated the proportion of worldwide exports that went to these 49 priority countries and the corresponding proportion of all exports supporting U.S. jobs related to exports to these countries. In Part 2 of the analyses, we estimated the impact on the U.S. export economy of an illustrative infectious disease outbreak scenario in Southeast Asia that had 3 stages, starting in 1 country, and if left uncontained, spread to 9 countries. We used the 2014-2016 West Africa Ebola epidemic-related World Bank estimates of about 3% and 16% reductions in GDP or gross domestic product for these analyses. We also calculated export-related jobs at risk to any outbreak-related disruption in U.S. exports. Okay, now on to the results. In Part 1 of the analyses, we found that the total value of U.S. exports to the 49 priority countries was more than $308 billion, including over $225 billion in material goods and over $85 billion in services exported. This represented about 14% of all U.S. exported material goods worldwide. Overall, in 2015, U.S. exports of material goods and services to these 49 priority countries supported over 1.6 million jobs, or about 14% of the U.S. total of over 11 million export-related jobs. And this world map shows the number of jobs supported by U.S. exports to global health security priority countries according to the destination in 2015. The largest numbers of U.S. export-related jobs were linked to exports to priority countries in Asia. Number of U.S. jobs supported by these exports varies greatly by volume of exports per destination country. For example, exports to Montserrat were quite limited, and only 30 U.S. export-related jobs could be attributed to that country. This state map shows the estimated value of 2015 U.S. material goods exported to the 49 global health security priority countries. The sector-specific proportions of exports varied by state. The total value of material goods exported from specific U.S. states to the 49 priority countries varied, with Washington of about $29 billion, California with $27 billion, and Texas with about $26 billion having the largest export value. These states are colored in the very dark purple. California, Texas, and Washington also were the largest exporters of manufactured goods to priority countries, with each exporting more than $25 billion. For agricultural exports, Louisiana had the largest export value of nearly $6 billion. After Louisiana, states with the next largest agricultural export values were Washington, California, Texas, Illinois, and Ohio. So now I'm going to discuss some of the results from the second part of the analyses, which is the hypothetical outbreak. In this table, this shows the illustrative scenario by stages of spread of this hypothetical outbreak and the countries listed in the different stages. For example, in stage 1, only 1 country is affected, which starts in Cambodia. In stage 2, the outbreak actually affects 5 countries in addition to Cambodia. And then in stage 3, it spreads to an additional 3 countries for a total of 9 countries in the region. Okay. In this analysis, we estimated losses of U.S. exports associated with stage 1 of this illustrative outbreak, so the outbreak only occurring in 1 country in Cambodia, to range from about $13 million to about $64 million, and to place about 1,500 export-related U.S. jobs at risk. If the illustrative outbreak were to expand to all 9 countries in the illustrative outbreak scenario, which is stage 3 and shown here in the continental reach of this infographic, the potential loss of U.S. exports would increase to a range of about $8 billion to $41 billion, with almost 1.4 million export-related jobs at risk. This hypothetical outbreak could place an estimated 1,500 to almost 1.4 million export-related jobs at risk, depending on how widely it spread. In 2015, the U.S. had over $300 billion in exports to CDC's 49 global health security countries. There are over 1.6 million U.S. jobs across the U.S. that support our exports to these countries. This substantial economic export activity to the 49 priority countries suggests that economic disruption in those countries, including those associated with infectious disease outbreaks, could result in reduced demand for U.S. exports. The U.S. export economy is vulnerable to economic disruption, and such disruptions could negatively affect U.S. export supporting jobs. Our illustrative outbreak scenario shows the cost to the U.S. export economy of a single country outbreak and the exponential increases in cost if the outbreak escalates from one country with a maximum cost of about $64 million to a maximum cost of about $41 billion if the outbreak spread to 9 countries. And sorry, I'm discussing the public health implications now. Our analyses had several limitations, at least 2 of which were due to the nature of available data. We lack service export data for 39 of the 49 priority countries, which means that we likely underestimated the value of exports and associated jobs for these countries. Our point in these analyses was not to generate a precise estimate of potential loss in analyzing this hypothetical outbreak. Rather, our intent was to provide policymakers with an order of magnitude of possible losses and also provide an estimate of the reduction in U.S. exports and jobs at risk. Even if, for example, our estimates were reduced by 50%, the impact on the U.S. export economy of an uncontained outbreak in 9 countries would be considerable. Additional studies and evaluation on outbreak investigations are needed to better measure costs, especially for zoonotic outbreaks. The results from these 2 publications clearly demonstrate that there is value in investing in systems, including building capacity in detecting zoonotic diseases and zoonotic surveillance systems that can notably increase the probability of early detection of an outbreak of an infectious disease, and 2, ensure a rapid and effective response that successfully contains the outbreak before it spreads to other countries and protect Americans and the U.S. economy. Finally, the economic vulnerability of the U.S. to infectious disease outbreaks is likely to extend well beyond just exports and export-supporting jobs and include broader and potentially larger impacts stemming from the fear of contagion on travel, tourism, and imports, especially if cases occur in the United States, as they did in the 2014-2016 West Africa Ebola outbreak. I'd like to thank the co-authors of these studies, including myself and the authors listed here, and collaborators and reviewers as well, including Chris Rasmussen with the U.S. Department of Commerce. And then you also have a list of resources. Thank you.
Thank you, Dr. Castle. Our final presentation, Emerging in the United States, Antifungal Resistant Aspergillus fumigatus Associated with Environmental Fungicide Use, is by Dr. Carlin Beer. Dr. Beer, you may begin when you're ready.
Great. Thanks, Helen. Thanks so much for inviting me to present. I know aspergillus might not keep you up at night, or maybe you haven't heard much about it. But I think this will be a familiar story because it's a story about antimicrobial-resistant pathogens, antimicrobial use in agriculture, and their effects on health and disease. Aspergillus fumigatus causes invasive aspergillosis and a spectrum of other chronic and allergic presentations. Invasive infections have a 50 to 90% mortality. About 1.5% of bone marrow transplant recipients have gotten aspergillus infections in the year after their transplant in a recent study. And the disease is usually in the sinus or lung, especially in immunocompromised patients like those with transplants or those who have had cancer. There's no U.S. surveillance for this disease as it's not reportable or notifiable in the United States. And while I won't be talking about zoonotic aspergillus today, We do know that poultry, especially turkeys, can become infected with Aspergillus, and we're interested in this as well, especially understanding how poultry can help us understand the epidemiology of aspergillosis in the U.S. Azole antifungal medications are the first-line treatment for aspergillosis, and these are voriconazole, itraconazole, and posaconazole. Resistance to azoles is emerging, with major consequences for patient survival. Azole antifungals first were introduced in the 1990s, which we're calling the azole era, and they dramatically improved the survival of invasive aspergillus infections. Resistance had emerged since the late 90s to the early 2000s, and now mortality approaches 90% for infections with resistant strains of A. fumigatus. Azole-resistant A. fumigatus has been identified around the world, and this map from 2016 is already out of date. For example, resistance was recently reported in Korea, which isn't shown here. And in Europe, azole resistance has increased since the mid-2000s. This plot shows the prevalence of azole resistance among cases of aspergillosis in one UK center. And these are older data, but other more current studies from Europe indicate that anywhere from 5 to 30% of A. fumigatus isolates are resistant, and that varies by country and by center. Along the way, physicians and researchers in the Netherlands were sequencing the azole drug target gene called CYP51 in resistant isolates. In the beginning, most resistant isolates had various point mutations, but two other genotypes emerged with some interesting characteristics, including pan-resistance to all three antifungals used to treat invasive aspergillosis. I wish they had more charismatic names, but they're called TR34, L98H, and TR46Y121F. The TR just stands for the tandem repeat in the promoter region, you can see on the screen in blue, and L98H indicates the substitution of a histidine for a leucine at position 98. But we'll just call them the TR genotypes for short, and the first one was identified in 1998 in the Netherlands. As TR-resistant strains emerged in Europe, the hypothesis arose that TR strains acquired their resistance mutations in the environment and not in the body of a patient taking antifungal medications. In the patient route, a patient inhales the spores of a susceptible isolate, and under selection pressure from medical azole antifungals, maybe a patient is having prophylaxis after a transplant to prevent a fungal infection, that susceptible isolate replicates and acquires resistance mutations that enable it to survive even in the presence of a medical azole treatment. By contrast, in the environmental route, susceptible strains of A. fumigatus live naturally in soil and compost, and they're exposed to fungicides, like those used to prevent fungal diseases in crops. Resistance mutations then arise under selection pressure of the fungicide, and then a resistant strain can be inhaled by a patient, leading to a resistant infection. This environmental route hypothesis was supported early on by several Dutch studies from 2007 to 2011, which found that patients with TR-resistant isolates appear to be different from patients with other resistant isolates. Patients with TR-resistant isolates could have any presentation of aspergillosis, whereas those with non-TR-resistant genotypes had a very specific type, often of allergic aspergillus, called a lung cavity. They also found that among TR-resistant genotypes, patients with TR resistance, more than half, 64%, had no prior azole exposure, whereas non-TR-resistant genotypes, those patients had previous azole exposure, such as prophylaxis. We also find that compared to patients with TR resistance, non-TR resistant genotypes had multiple different types of mechanisms as opposed to these two exclusively. Patients with TR resistant genotypes have isolates that are highly genetically related. When you sequence them, they're very similar, whereas resistant isolates with non-TR genotypes are very genetically diverse. And the TR-resistant genotypes have no apparent survival disadvantage, meaning that carrying that resistance mechanism results in no loss of survival for the organism, whereas carrying the other resistance mechanisms means that those molds do not grow as well, or those aspergillus don't grow as well. And finally, the TR mutations have risen to become dominant genotypes in Europe, whereas the others have declined in proportion. Meanwhile, the Earth's population is over 7 billion people, and that growing population puts an increasing demand on agriculture. The majority of agriculturally important plant pathogens are fungi, and azole fungicides, such as tebuconazole, shown here, are used to treat and prevent crop loss. This plot shows global agricultural fungicide usage from 1990 to 2014, with year on the x-axis and metric tons of active ingredient on the y. Each line represents a different class of fungicides, but the red line shows the usage of azole fungicides and that it's increasing. Importantly, these azole fungicides are chemically and structurally similar to the medical azole antifungals used to treat aspergillosis, and they're attractive for use in agriculture because you can use very little active ingredient per acre. In the United States, azole fungicide use has increased about 500% from 1992 to 2014. And this plot shows estimated annual use in kilograms for triazole fungicides, such as tebuconazole, propiconazole, and difenconazole. Just to put it all together, wild-type susceptible A. fumigatus living out in the environment can be exposed to azole fungicides and develop resistance, including TR resistance mutations. We all breathe in aspergillus spores every day, but when an immunosuppressed patient inhales them, they can develop aspergillosis infections that are no longer treatable with medical azoles. Since these TR-resistant strains first emerged in 1998, they've been identified in patient clinical samples on 6 continents and account for the majority of resistant isolates in Europe. They've also been identified in the environment, in soil samples, flower bulbs, compost, and even in people's homes, in the Netherlands, Ireland, Denmark, Switzerland, Germany, the UK, Colombia, Iran, Thailand, Kenya, and a peanut field in Georgia. And these are just the countries where this has been published. Today, there's a large body of evidence that links the emergence of the TR-resistant strains with environmental fungicide use. Unfortunately, I don't have time here to discuss each of these in depth, but I've listed the key pieces of evidence, and I'm happy to share the papers that support each one of these. TR-resistant isolates have emerged in the United States, and the Mycotic Diseases Lab at CDC has collected over 2,300 isolates now from clinical labs across the country. A recent paper described 1,356 isolates, of which 20 were resistant to azoles. Of those 20, 5 isolates from 3 states had TR34 mutations. This last week, we published the descriptive epidemiology of these 5, plus an additional 2 previously published isolates from the United States. Of those 7 total isolates, all had the TR34 resistance mechanism. 2 were from Pennsylvania, 1 from Virginia, and 1 from California. 4 of the 7 had no previous azole exposure, meaning the patient route of resistance is unlikely, and 3 of the 7 had invasive pulmonary disease. None of the 7 were epidemiologically linked. Over the last few years, environmentally associated TR-resistant A. fumigatus has emerged in the U.S. In the Mycotic Diseases branch, we're developing surveillance systems for invasive aspergillus infections, as well as continuing to collect isolates from U.S. clinical labs. We're analyzing fungicide usage patterns from a number of U.S. data sources, and we think it's important for that capacity for antifungal susceptibility testing in the U.S. be expanded. And we want clinicians and microbiologists to be aware that resistance is out there, to look for it in patients who don't respond to azole treatment and in those with no prior azole exposure. Finally, as I mentioned, the story is not a surprising one because we know that antibiotic usage in agriculture has been associated with resistance that can threaten the medical antibiotics that we have. So I'll take this last slide to remind everyone that when talking about antimicrobial resistance, or AMR, antifungals are antimicrobials too. Thanks so much. And since this week is Fungal Disease Awareness Week, we want to encourage everyone to think fungus when infections don't get better with treatment. Thanks.
Great. Thank you so much, Dr. Beer. You just advance here to the end. We will take questions now. So if you have any questions, please press *1 and say to Amanda, the operator, your name and let us know your affiliation and also which presenter or topic you're asking a question about. If you haven't already called in, please call 1-800-593-8936 and enter the participant passcode 9611836. Again, press *1 and give the operator your name and affiliation. Amanda, do we have any questions yet?
Thank you. One moment. Our first question comes from Kate. Your line is open. Please state your affiliation and which presenter your question is for.
Hi, thank you. This is Kate from the CDC, and my question is for Dr. Campbell. I'd like to know, what do plague symptoms in dogs and cats commonly look like?
Thanks for the question. So generally with dogs, most of the time we believe that they may be subclinical, but when they do have clinical illness, we often see fever, possibly enlarged lymph nodes, infrequently, sometimes lethargy, and coughing of blood or mucus is also reported in dog plague cases. With cats, more often they are symptomatic, and we see fever, enlarged or abscessed, usually submandibular lymph nodes, as well as lethargy and anorexia. So those are, in domestic animals, what we commonly see.
Does that conclude your question, Kate?
Yes, thank you.
Thank you. At this time, we have no further questions, but as a reminder, please press *1.
Amanda, Dr. Beer has a question for Dr. Campbell.
Okay.
Hi, Dr. Campbell. This is Carlin. Thank you for your talk. I'm wondering if you had any information about occupation and industry among the plague cases. I know that 4 of the 6 pneumonic cases who provided care to animals were vets, and I wondered if you knew anything about perhaps laboratory workers or zoo employees.
Thanks for your question. So we do have that information available to us. We did not take a very close look at it for this early analysis. I do believe some of them were wildlife, biology type workers, as well as, like you mentioned, veterinarians were in there pretty frequently. And that's really, I think we do just need to do a closer look at what's in the database, but that will definitely be included in future analysis.
Great, thank you.
Do you have any new questions come in, Amanda?
We do. Our next question comes from Ivney. Your line is open. Please state your affiliation and which presenter your question is for. Ivney, your line is open. At this time, there are no further questions.
Okay. Well, I will go ahead and wrap up the call with some more information about the continuing education. Instructions for receiving free CE credits are available at www.cdc.gov/onehealth/ZOHU continuing education. The course access code is One Health 2018. To receive free continuing education for today's webcast, WC 2962-100318, complete the evaluation at cdc.gov/TCE online by November 4th, 2018. A recording of today's call will be posted by November 5th, 2018 at cdc.gov/onehealth/ZOHU 2018/October.html. To receive free CE for the Web on Demand WD 2962-100318 video of today's call, complete the evaluation at cdc.gov/TCE online by November 5th, 2020. Our next call will take place on Wednesday, November the 7th at 2 p.m. Eastern Time. For more information, please visit cdc.gov/onehealth/ZOHU. Please send suggestions and questions to zohucall@cdc.gov. Thank you again for your participation. Goodbye.
That concludes today's conference. Thank you for participating. You may disconnect at this time.